next speaker is speaking about change over time and moving new ideas into practice. Dr. Dahala is a general internist and Vice President, Evidence Development and Standards at Health Quality Ontario. He is the province's advisor on healthcare quality. He continues to practice in general internal medicine at St. Michael's Hospital, where he cares for inpatients and teaches medical students and residents. He is also an assistant professor in the Department of Medicine at the University of Toronto. Please welcome Dr. Dahala.
Thank you, Janet, for that lovely introduction. One minor correction, if I will. So I am not the province's advisor on the quality of healthcare. Health Quality Ontario is, and I have the privilege of working at Health Quality Ontario, but we have a whole team, and together we advise the government. It'd be pretty cool if I was the sole advisor, but not the case. I'm really, really delighted to be here today and to have the opportunity to chat with you, see some friends in the room, about a topic that is near and dear to my heart, and I suspect near and dear to the hearts of many of you in the room. This is a picture of Ignaz Semmelweis. And I wish I could stand up here and say that his is a story of triumph, of of evidence over dogma. David beats Goliath, one of those stories. There are stories like that, but this is not one of those stories. This is actually a cautionary tale. In 1846, the 28-year-old Semmelweis found himself working as an obstetrician in a hospital in Vienna. And the hospital had 2 clinics where women delivered babies. And in the first clinic, 1 out of every 35 women died after giving birth. And that seems like a lot to see some raised eyebrows. But in the second clinic, 1 out of every 9 women died after giving birth. And so in the year 1846, there were 105 deaths in the good clinic and 459 deaths in the bad clinic. And everybody in the city knew about the difference between these 2 clinics, and the difference was so profound that the women in Vienna begged to deliver their babies in the good clinic, and the hospital had this policy where they just alternated days. If you showed up on Monday, you went to the good clinic. If you showed up on Tuesday, you went to the bad clinic. And women would really, some women, if it was the bad clinic's day, would actually deliver their baby en route and then show up at the hospital. And I don't really understand why, but there was some benefit to actually showing up at the hospital, even if you delivered your baby. And so Semmelweis was working at this hospital, and so he began systematically examining the differences between the 2 clinics to understand why women were so much more likely to die in one of these clinics than the other. And so, he looked at things like, did the clinicians in one clinic use a different technique to deliver the babies? The answer was no. Were the mothers different in one clinic compared to the other? No. Was overcrowding a factor? No. Did the staff in one of the clinics pray more than in the other clinic? He looked at that. The answer, in case you're wondering, was no. And then one day in 1847, a friend and a colleague of Semmelweis cut himself with a scalpel that had been used in an autopsy, and he very quickly became ill, and a few days later he died. And Semmelweis was a pretty careful observer, and what he observed was that the illness and the pathology in his friend was pretty much exactly the same as the illness and the pathology in the women who were dying. And so, he soon after that he reasoned, or he made the realization that in one clinic there were medical students working, and they were going back and forth between the delivery room and the autopsy room. And in the other clinic, there were no medical students, it was just midwives, and they weren't going to the autopsy room. And so, he conjectured that there was some sort of contaminant coming from the autopsy room and resulting in illness in the women and their death. And so he instituted a very simple solution. You heard about it from the last presenter, hand washing. And in April 1847, the mortality rate in the bad clinic was 18%, nearly 1 out of every 5 women that month. He instituted hand washing in May, and the next month the mortality rate was 2%, 1 out of every 50, 18% to 2%, and the month after that it was 1%, just 1 in 100. So, if this were a story of triumph, I would now tell you that the evidence moved into practice, right? It spread around the world, the hand washing rate went down, or the hand washing rate went up, the maternal mortality went down. But that is not what happened. In fact, Semmelweis and his students, they did talks like this. They published their findings in journals, good journals, journals that other physicians were reading, journals like The Lancet. But nobody listened. And to be fair, this was before, before the work of Louis Pasteur. Nobody had a concept of bacteria. I don't even think the word bacteria really existed. And so, people didn't know how to make sense of Semmelweis's findings. And over the ensuing years, Semmelweis continued to try to promote his findings, to move his new idea into practice, and nobody listened, and he grew angry, and he began to treat people badly, and people responded in kind. They started to not like Semmelweis, and by 1865 he was obsessed. He was drinking too much, and eventually a friend of his had him committed to a hospital for the mentally ill. And he died there just 2 weeks after he was admitted, ironically, of a bloodstream infection himself that was probably a result of a beating that the guards gave him. And he was only 47 when he died. And so his new idea did not change practice, or at least not during his lifetime. So contrast his story with the story of Naileen Fox, another not so great story. So Naileen Fox died of metastatic breast cancer in 1993. She was 39. And she died after receiving a very aggressive treatment for breast cancer. Ultra high dose chemotherapy followed by bone marrow transplantation. And during the 1980s and 90s, not so much in Canada, but especially in the United States and to some degree in Europe, about 30,000 women with breast cancer were treated with bone marrow transplantation. So this was a new idea too, but it wasn't a good one. There was actually no good evidence to support the use of ultra-high dose chemotherapy and bone marrow transplantation in women with breast cancer. And a decade later, by the year 2000, we had learned that. We knew that from good randomized controlled trials, well-designed, meticulously conducted. And by the year 2000, we knew that bone marrow transplantation for women with breast cancer did more harm than good. But in the interim, when a new idea did change practice, even though it was a bad idea, not because of evidence, but because of faith, several thousand women died because of the adverse effects of treatment and not because of their disease. So, the first key message I want to share with you today is that not everything that is evidence-based changes practice, and not everything that changes practice is evidence-based. So for the first part of this message, think Ignaz Semmelweis and hand washing. And for the second part of this message, think Naileen Fox and bone marrow transplantation for breast cancer. So, someone in the room is probably thinking, well, that Ignaz Semmelweis story was totally crazy, might have even heard it before, but wouldn't happen today, 2017. So, to the person in the room who's thinking that, let me just give you a current example. So some of you in the room know I work at Health Quality Ontario. We recommended recently that offloading devices, including total contact casting, should be publicly funded for people with diabetic foot ulcer. I thought I would go back and actually look at the evidence and see when the first randomized controlled trial for offloading in patients with diabetic foot ulcer was published. Any guesses? What's it? 1990s? So I heard 1960, I heard 1990s. The correct answer, you guys are pretty good, actually 1989. So the year, my kids would say the year Taylor Swift was born. So, she's still pretty young. But that's nearly 30 years ago. So 30 years passed between the first trial, and that's the first trial I found. Maybe there was a trial in the 1960s. Between the time that trial was published and our recommendation. And we all know in this room it will take many, many more years, hopefully not 30, before every patient with a diabetic foot ulcer in Canada is offered offloading as part of their treatment. And I don't need to tell you, you know this better than me for sure, if we used offloading in every patient with diabetic foot ulcer and used it well, we'd prevent hundreds, maybe even thousands of amputations every year in this country. This is a picture of James Lind. So James Lind was born a century before Semmelweis. He joined the British Navy as a teenager, became a surgeon's assistant. He loved the work so much, he decided to train and become a surgeon himself. And by the time he died, he was probably the world's leading expert on scurvy. Most of you probably heard about scurvy, a disease caused by an absence of vitamin C in the diet. Nobody gets scurvy really in Canada in 2017. So rare. I've seen one case in my career, or at least one case that we recognized. Maybe we've missed cases. Generally only occurs in people who have a mental illness and who aren't eating a normal diet. But for a surgeon in the Navy, in the British Navy in the 18th century, this was super common. To give you a sense of how common it was, in one sailing expedition that left the British Isles in 1740, there were 961 sailors. By the time they landed off the coast of South America, 626 out of the 961 were dead, and almost all because of scurvy. So, and Lind was a surgeon working on these ships, trying to figure out what was going on, and so he did basically what was the first controlled clinical trial. He took 12 sailors with scurvy. I guess this is a painting to represent what was, what he did. He took 12 sailors with scurvy. He gave 2 of them vinegar, 2 of them salt water, 2 of them cider, 2 of them sulfuric acid, 2 of them a laxative, and 2 of them lemons and oranges. And you probably all know how this story ends. The 2 who got the lemons and oranges got better very quickly. Within days, they were up and walking. Their energy level was good, and the others didn't. And although, again, as with Semmelweis, nobody really understood why vitamin C hadn't been discovered, didn't know why people got scurvy, but it only took Lind's experiment to conclude with a reasonable degree of certainty that lemons and oranges could be used to treat scurvy. And unlike with the Semmelweis story, by the time Lind died in 1795, scurvy had been eliminated from the British Navy, at least. And James Lind has gone down in history as the first physician to perform a controlled clinical trial. So, there are actually 2 discoveries that Lind made, and they're sort of wrapped up with each other. The first is the discovery that lemons and oranges could cure scurvy, a very important discovery, to be sure. Saved the lives of many sailors and probably others too. But the second discovery, in some ways, certainly more subtle, and maybe in the long run even more important. And that discovery was refined over the next couple hundred years, and to be honest, continues to be refined today. And that discovery is that the controlled trial, and even more so the randomized controlled trial, is the fairest way to evaluate the benefits and harms of a particular treatment. And so, one question we all face, maybe more so than ever in this era of fake news, is how do we know what to believe? Right? How do we know whether what we believe is true or not? Humans have been trying to figure this out, forever. We were probably trying to figure this out before we were even humans. If you have a pet, dog or cat, your dog is always trying to figure out what is true, where are you hiding the food. Animals try to figure this out too. And there are a lot of different ways of trying to figure out the answer to this question. Historians have their techniques, physicists have their techniques, and healthcare professionals, particularly when it comes to treatments, do you believe that this, or do you know that this treatment helps or harms, increasingly use a system called grade. Whether you as a healthcare professional know about it or not, and I'll get to why you're probably using it even if you don't know about it. So over the last 15, 20 years, Gord Guyot and his colleagues, particularly at McMaster, but really around the world, have developed this thing called the grade system. And they have a grade working group. They'll accept pretty much everyone. It's a pretty democratic process. And they've developed a transparent and a reliable, a replicable, common sense way of assessing the quality of evidence and translating that evidence into strong or weak recommendations. And lots of organizations around the world use this. The organization I work at, Health Quality Ontario, uses this. The Canadian Task Force for Preventive Healthcare uses this. Up to Date uses this. The World Health Organization uses this. And this is why I said a few minutes ago that you're probably using grade whether you know it or not, because if an organization makes guidelines and you follow them, and the organization uses grade, well then you are using grade too. And basically grade lets you do two things. The first is to assess a body of evidence. It can be as small as one study, it could be a randomized controlled trial, could be an observational study, or it could be dozens of studies, some randomized trials, some observational studies. Grade lets you look at that body of evidence in its totality and answer that question: how do we know? How do we know whether this is true? How do we know what to believe? And grade helps people do this by providing people with a systematic approach. Basically, grade makes you ask questions like first of all, is there a difference between two treatments or two tests? How big is the difference? Is there a dose-response effect? If there are multiple studies, do they say the same thing or do they disagree with each other? How precise can we be about the conclusions? Are there reasons these studies might be biased? Maybe people who were doing the studies weren't blinded and they treated one group of patients differently than the other. That can make a difference. And actually that's a difficult thing in the wound care literature, where it can be really difficult to blind people, both clinicians and patients. Are the studies asking the question we're actually interested in? Like, are they looking at whether wounds heal or not? Or are they looking at some surrogate measure that may or may not be correlated tightly with whether wounds heal? And so, people go through these kinds of questions systematically, and then grade provides almost an algorithmic approach for making a determination about how certain we are about the evidence. So for example, if you take something like offloading for diabetic foot ulcer, we can say we are highly certain that offloading improves wound healing. But if we take other treatments like hyperbaric oxygen, people who use grade would probably say we have low certainty whether hyperbaric oxygen works for diabetic foot ulcer. And we can also say we have high certainty about ineffective treatments. So, if folks were to take the grade approach and look at homeopathic treatments, probably we would conclude that we have high certainty that those treatments don't work for diabetic foot ulcer. You laugh, but actually, many of our patients use those kinds of things, right? In fact, the NHS in the UK still pays for homeopathy. So that's the first thing that grade does. It allows people to answer the question, how certain can I be about this conclusion? The second thing grade does, and this is, arguably as important, is standardize the process of making recommendations. And there are two kinds of recommendations in the grade system: strong recommendations and weak recommendations. And so a strong recommendation is one when you look at the evidence, the cost, values and preferences, you can pretty much assume that almost everybody would want that test or that treatment. And so actually offloading, I keep coming back to this, offloading for diabetic foot ulcer is an example of something that would, generally speaking, get a strong recommendation. Weak recommendations occur when there are trade-offs. And those trade-offs can be different. They can be trade-offs between benefits and harms. They can be trade-offs between benefits and costs. They can be trade-offs related to values and preferences. Maybe somebody doesn't want to come to the clinic every day for some sort of treatment. And so that might lead to a weak recommendation. So to give you an example, the Infectious Disease Society of America, they use the grade system, and they made a weak recommendation about negative pressure wound therapy for diabetic foot ulcer. I think their view is that the quality of evidence isn't very high, it's a very expensive treatment, so they've balanced those things. There's a trade-off, and so they made a weak recommendation. One subtle point about the grade system, and it's an important point, but not one I'm going to get into in a lot of detail, is that high-quality evidence doesn't necessarily imply a strong recommendation. And that's because of the trade-offs. So you can have really, really good evidence, but if the benefits and harms are sort of balanced, or a values and preferences issue might result in some patients making one decision and other patients making another decision, that should lead to a weak recommendation, even if there's really good evidence. And the converse is also true. You can have low-quality evidence and a strong recommendation. Usually those would be strong recommendations not to do something where there's a risk of harm and there's a reasonable alternative treatment. So just to keep that in mind. So, my second key message is that not all evidence is the same. Not all evidence is equal. And we need to assess the evidence, the quality of the evidence, and consider values and preferences before we decide what we want to move into practice. And this work isn't easy, appraising the evidence and making recommendations. We have staff at Health Quality Ontario who do this. There are other organizations in the country that do this. And most of the people who do this would have master's degrees or PhDs, and they wrestle with really, difficult methodological issues. And it's hard to appraise the evidence. It's arguably even more hard to make recommendations because people have a lot of discomfort. Who am I to say what you should do? It's sort of easy to want to pass the buck, or at least the kind of people who we want to make recommendations are the kind of people who wrestle with it and who find it difficult. If you meet someone who's sort of too easy to give you advice, they're the people whose advice you don't want. Everybody has a friend like that, right? But the really hard part is translating the evidence and the recommendations into practice. And so this is a brand new book. In fact, if you buy it, you'll see the inside cover says it was published in 2018. And maybe reading it will give you a glimpse into the future. I bought it actually. I bought it about a month ago, and it arrived maybe a couple weeks ago. And I'm about a third of the way through, so I can't tell you everything that's in the book. But the author, Trisha, Hogg, she's a British general practitioner, and she's been writing about this stuff really for decades. And probably some of you in the room have read some of her papers, or if not, I recommend reading some of them. They're all very good, and so I feel like I've read enough of them that I have a bit of a sense of what she's going to say in the book. But I thought it would still be good to have it all in one place and to hear what her latest thinking about this is. And very few people, I would say, have probably thought as deeply and as creatively about how to implement evidence-based healthcare as Trish Hogg. And I will read you the chapter titles because I think it gives you a sense of everything we need to think about. And as I read them, what I might sort of ask you to do is think about the cases or the stories of Ignaz Semmelweis and James Lind in your head. Why was it that one new idea did not make it into practice for decades, maybe even more than a century, and the other new idea made it into practice really quickly and very quickly eradicated scurvy in the Navy? So the first chapter in her book is called Evidence, and we've talked a fair bit about that. But then the chapter titles go people, groups and teams, organizations. Most of us work in organizations. We know they're complex animals. Citizens, patients, not CE, but patients TS. It's nice to hear there's some patients in the room today. Technology, policy, networks, and systems. So, basically everything. That's the problem. And this leads to my third key message, which is moving evidence into practice isn't rocket science, it's harder. And I'll read you a quote from Trisha's introduction that sort of makes this clear. She says, "Let me break this news to you gently. There is no tooth fairy." My daughter would be so disappointed. She's not here today. Implementing research evidence is not just a matter of following procedural steps. What we need to do, Trisha argues, is in some ways common sense, but in some ways really, really hard, which is to make contextual judgments about what is likely to work in this situation with these people in this organization with these constraints. And so it'd be nice to hear that, there's a recipe, like there is a recipe for using grade, and that it was simple. And I wish I could tell you that it was simpler than what Trish just said, but I don't think it really is. And what, as Janet said, I work at Health Quality Ontario, and we are privileged that our work is to try to help people do this, put evidence into practice and implement evidence-based healthcare. And we try to do this in a number of ways. First, we lay a foundation by making evidence-based recommendations about what should be publicly funded and also about standards of care. And some of you in the room were involved with the development of our quality standards for diabetic foot ulcer and pressure injuries and venous leg ulcer. And I particularly want to acknowledge the leadership of Laura Teague, maybe stand up, and Gary Sibbald, if he's still here. Gary's there. So Laura and Gary co-chaired our Quality Standard Advisory Committee that did this work. There are others in the room who I know were on the committee too. And we've also been really fortunate to have the support of Miriam Botros, who's the CEO of Wounds Canada, as probably everybody in the room knows. And so we released drafts of these standards several months ago. We've incorporated feedback. We've finally gotten our board to approve, and they will be released publicly early next month. But the recommendations really are only the beginning, right? Building on our recommendations as well as those made by many others, then we do the hard work of working with patients, clinicians, organizations to implement evidence-based healthcare. And I thought I'd spend a couple of minutes just touching on a few of the ways we do this, because there's some of the ways that you can do this in your own organization, wherever you work. So one thing we do at Health Quality Ontario is we try really hard to provide data to clinicians about their own care. And in particular, we've started with family doctors, long-term care homes, and general surgeons. So if you're a family doctor in Ontario, you can sign up on our website to get a report about the quality of care that you deliver and a comparison to the practices of your peers around the province. We also work with organizations to help them develop their what are called in Ontario quality improvement plans. So every hospital, every long-term care home, every community health center, every family health team has to produce, and home and community care funders, now the local health integration networks, produce quality improvement plans and submit them to us. We work with them to help them design these quality improvement plans, and then try insofar as we can with the resources we have to support them in implementing their quality improvement plans. We also support networks and collaboratives. So, going back to Trisha's chapter titles, one of her chapter titles was networks. We support quality improvement networks and collaboratives. Probably our biggest and best is one called the Ontario Surgical Quality Improvement Network. About 60 hospitals have signed up to do this, and together they're working to improve the quality of surgical care across the province. We also help build capacity. So going to Trisha's title, or Trisha's chapter titles, thinking about people, individuals, groups, teams, we build capacity. So together with the University of Toronto and the Institute for Clinical Evaluative Sciences, we have trained more than 2,000 healthcare professionals in some of the techniques that can help improve quality, and also just a common language so people are talking about the same thing. We work with academics so that proven interventions can be spread across the province. For example, we, in partnership with the Council of Academic Hospitals of Ontario, we deliver something called ARTIC, Adopting Research to Improve Care, and so do things like spread evidence-based models of care. Rapid access addiction clinics is one example that comes to mind across the province. And finally, a key part of our mandate is to report to the people of Ontario and the government on the quality of healthcare in the province. And we do this, we do this because we're required to by law in part, but really we do this because we hope that these reports at the provincial level, going back to Trisha's title, help shape policy, either through regulation, legislation, government decision, etc. And at the local level, whether it's an organization or a regional health authority, we hope these reports help people allocate resources, focus their attention on the problems that we're really seeing, give people data so that they can make the right decisions. And we do this, of course, in partnership. So in partnership with people like you, people who take care of people, people who receive care. We work a lot with patients. And basically with people who share our vision of excellent care for every Ontarian. We're Ontario-based, but I realize many of you from out of the province, but hopefully you have similar organizations in your own province that are working to improve care for everyone. And so I'll leave you with a final quote from Don Berwick. I really owe some credit to my wife for this. It's really her favorite quote, but I've stolen it. It's really a Don Berwick quote, though. Not all change is improvement, but all improvement is change. So the first sentence here takes us back to Nalene Fox. And it's really, really important to separate the changes that are likely to be helpful from the changes that are likely to be harmful. And some of the changes that are harmful are just the changes that are useless, right? And the changes that are useless are also harmful because they distract us from the changes that really matter and because they waste our resources. So not every change that's harmful has to be as dramatic as the change that may have accelerated Nalene Fox's demise. Not all change is improvement. But it's the second sentence here that really has to drive us forward, right? So all improvement is change, and change is hard. Changing, your habit in the morning is hard. Changing what other people do is hard. Change is hard. Harry Levinson has said that all change is loss, and part of our job is to identify where the loss happens and manage that loss. But without change, we have no improvement. So I would argue our job, the people in this room, the people in the healthcare system, is to make the changes every day that lead to improvement. And that's really how we move evidence into practice, and we do it together, and our patients deserve nothing less. So thank you for listening to me today.